So, hello guys, how are we doing today?
We are good, doctor.
Oh, thank you. So, almost 12 students have joined the class. Let's wait for the other to join, and then we will start the today gastroenterology MCQs. Okay, stay tuned. Thank you. So, let's start our today topic of the gastric anatomy and embryology, the remaining, and then we'll move further. And okay. So, does anyone practice yesterday MCQs? Is there any difficulty in the yesterday topic? Everyone can see my screen.
Yes, Dr. Imran.
Okay, thank you. So, who will be the first volunteer to read the question? And the point I discussed yesterday was that almost 15 to 20 students have joined the session, and almost so try to give a chance to the students so they can participate and they can learn. It is attractive and friendly station. Okay, so who will be the first volunteer, and can you go with it? Okay.
Can I go?
Yeah, doctor. Yeah, what's your good name?
Dr. Rahul Ranawat.
Okay, Dr. Rahul, you can go ahead. Okay.
Okay, thanks, sir. Chest radiograph is shown in the image below. A
Mhm.
3-hour-old girl is being evaluated in the neonatal intensive care
Okay.
unit due to respiratory distress and an episode of cyanosis, endotracheal and orogastric tube are inserted. An
Mhm.
umbilical venous catheter is placed.
Okay.
Test radiograph is shown in the image below. Which of the
Okay.
following is most likely present in this patient?
What do you think? What the chest X-ray is likely to you tell you about this?
Like OG2 is there.
Yeah, wait a minute. Let's discuss it in a detail so that you know that. Basically, the tube that is passing over here, that this one tube, this tube is going through the oral cavity and passes down to here to the stomach. It is the orogastric tube. Okay, orogastric tube. And the another one that is passing over here, that is the endotracheal tube. Endotracheal tube. So this tube have stuck over here. Have you noticed the point? Okay. So there is a no further going of this tube over here. So which of the following is most likely present in this patient? Let's discuss the option bilateral nasal obstruction. So, sorry, in bilateral, in this option, whenever you put a tube, the nasogastric tube in nose, so it will block in the nose. So it will not go down. For example, this is a blockage over here. This is nose. This is your nasal cavity, and it is your oral cavity over here, and it is your pharynx, and it is your nares over here. Okay, and there is a blockage in the hair over here. Okay, okay. Have you got the point? This is oral cavity. So whenever you put a tube in the nasogastric tube, and there is a coronary atresia over here, so the tube will not pass into the esophagus. Okay, so but in this case, the tube has passed and reached the esophagus over here. Okay, so this option is incorrect. So blind ending esophageal pouch. So yesterday we have discussed the transesophageal atresia, fistula, and esophageal atresia. Okay, so basically in the transesophageal atresia, this is your trachea and this is your esophagus. Okay, whenever I put a tube over here, so this tube will remain in there, and if you do more insertion, it will be bring out through this pathway. So there will be a no obstruction of, there will be obstruction in over here. Okay, so there are many type of atresia that we've discussed yes in yesterday class, but let's discuss in a little bit brief that how many type. Almost there are 5 type of esophageal atresia and transesophageal fistula. The number one type is esophageal atresia with distal fistula. It is the most common type. For example, this is your trachea, this is your esophagus over here, esophageal atresia with the distal transesophageal fistula over here. Okay. So in this condition, there will be a following clinical feature. No insertion of the tube, number 1 point. There will be the air passes into the trachea, will enter into the esophagus, and those goes to the stomach. There will be a bubble present in the stomach. Number second point, first point, second point. Okay. Second, this stomach content will be enter into the esophagus and cause the aspiration pneumonia. Okay. These are the high yield point for the esophageal atresia with the distal transesophageal fistula. Number second, the true esophageal atresia. So then this is your esophagus, and this is your trachea, and this is esophagus, and this is esophagus. Okay. So what is the clinical feature of this? There will be no insertion of the tube. Okay. Number one. Second, there will be the air will be go to the lung. No any problem in the stomach or here. So no bubbles will be present in the stomach. No. Okay. Number three, there will be the no any chances of aspiration pneumonia, as this is a true atresia. Okay. Perfect. Number third, is your transesophageal fistula. That is like this. Esophagus, okay, and this is like this. Could you please mute your mic, doctor? This is your esophagus, and this is your trachea. So, what are the clinical feature of this third type? It is a transesophageal fistula. Okay, number one, the endotracheal tube will pass over here and will go down easily. Number one, there will be present of the bubble in the stomach. Number two, and there will be the chance of respiration pneumonia. Number three. Have you got the point? Okay, this is the third type. And what's the fourth type? So four type are the esophageal trachea with a proximal and distal fistula both. Is your trachea and fistula over here, proximal and distal. So whenever you put a tube in, that will goes into the trachea, okay, and this will lead also to the bubbles in thing present, okay, and third there will be aspiration ammonia over here. Okay, it's a very rare cause, but the most common cause is esophageal atresia with the distal fistula. It is the most common type. Okay, there's a disturbance going on. So could you please mute your mic, doctor, so we can move ahead? Okay, yeah. So what happened? We've discussed it. Okay, now this option. What is defect in diaphragm? In the diaphragm, if there is a diaphragmatic hernia, there will be at most two important signs. Okay, there will be the cyanosis directly after the birth. Okay, and secondly, there will be respiratory distress. And what will the chest X-ray finding? Number one, there will be a bowel in the thorax. Number one. Secondly, you will be having a gaseous in abdomen, gasless abdomen. There's the most common present in the just like parallel pulmonary and systemic circulation, and the right ventricular outflow tract obstruction is right ventricular obstruction is a tautology of Fallot, and parallel pulmonary artery ventricular circulation is basically your transposition of your great vessel. It is not associated with your endotracheal tube insertion. Whenever you put a tube, it is not blocking these two things. So I think you have got your answer. This tube has stuck over here, and if it's not going down, so it means that there is a no blind pouch that is present in the esophageal atresia. Okay. So whenever a patient, so have you got the point?
Yes.
Okay. So basically, there are the four types of the esophageal atresia I have discussed detail in the yesterday, but I've also give a review that this is basically, well, basically it is a primitive foregut that didn't develop in the early stage, and so that lead to the esophageal atresia. Okay, and let's move ahead. What's happening? The internet is not that poor. Not working. Yes. I think we have problem with your internet connection.
Sir, like, can you refresh it once?
Is it working? Wait a minute, refresh it. That if it is working or not. Yeah, okay. Any volunteers?
Sir, so the answer for the previous question will be like A, right? Conal atresia.
No, no.
B.
It is a blind of the esophageal atresia.
Okay. So the option is B, right?
Yeah, yeah, he's right. Can anyone read any new volunteer?
I can go, sir.
Okay, what's your good name?
Dr. Mahanur.
Dr. Manur. Okay, go ahead, Dr. Manur.
Okay. This patient's gallstone has most likely lodged in which of the following sites? A
Mm-hmm.
68-year-old woman comes to the emergency department due to a 2-day history of crampy abdominal pain and vomiting. The patient has had no hematemesis, melena, or hematochezia. She has a history of hypertension, type 2 diabetes, and coronary artery disease. Several months ago, the patient had an episode of acute calculus cholecystitis that was managed non operatively. Physical exam shows a distended tympanic abdomen with high pitched bowel sounds. Abdominal x ray reveals air in the gallbladder and pylori tree. This patient's gallstones has most likely lodged in which of the following sites?
So yeah, a very technical issues. The the physical examination showed distended. So whenever the distended comes, so it means there is obstruction in bowel. Number one. Okay. X-ray abdominal reveals air in the gallbladder and biliary tree. What does it indicate? What does
Patient.
it? There is no any history of any
Hey,
trauma and this.
fistula between bowel, small intestine and gallbladder.
Can you explain it, doctors? Why there is a fistula formed between the gallbladder and the small intestine, and which part of small intestine?
Sir, duodenum.
It should be an ileocecal junction.
Where is the ileocecal junction? It the this no. My question is that the gallstones, the gallbladder, and there will be the fistula formed between the gallbladder. And how you diagnose it? It is the fistula between the gallbladder and the intestine.
Because air in the gallbladder.
Perfect. There is a air in the gallbladder and biliary tree. So it indicates that whenever the bowel, there is a air present in the bowel and is small gases present in the small bowel. Okay. So when on the X-ray, if there is a air present in the gallbladder, so it means the gallbladder had made a fistula and that lead to the air in the gallbladder. So what is the pathophysiology over here? The main pathophysiology over here is the patient is having the episode of recurrent cholecystitis. Whenever there is a recurrent cholecystitis, there any inflammation of wall, this wall have become inflamed and attaches to the small intestine. Whenever there is small intestine intention, so there will be a shedding of this cell. Whenever this the shell sheds, so this will lead the fistula formation between the small intestine and the gallbladder. Okay, have you got the point? So whenever there is a distended obstruction or hair distended, it means the destruction that takes place in the bowel intestine. Okay, so there is the history of stones or hair present stone. So whenever there is the formation of any fistula formation in between the gallstone and the gallbladder, inflamed gallbladder, and there is many stones present in it, this stone will be lodged over here and will go into the small intestine lumen. So my question is that where these stones will lodge? What do you think, guys?
Ilium? Ileocecal junction, because that is the narrowest part.
Perfect. That is the narrow part. For example, let's discuss it in the little bit. Goes to anatomy. For example, we're having esophagus, stomach, and then the duodenum first part, second part, and the third part and fourth part. Then we'll start the ileum, ileocecal wall, then jejunum, then we're having a cecum over here, and the ileocecal wall, and then we start the ascending colon, this transverse colon, and ligament colon. So this is the nearest part over here. So whenever this hair fistula over here, so that will lead to the accumulation of all the stone and it will accumulate over here. So this accumulation lead to the obstruction. So that obstruction will lead to the distension over here. Number one point, distended due to obstruction. That obstruction will be lead food present that will lead to distension over here. Okay, have you got the point? Secondly, whenever we look into the X-ray, X-ray show there is a air present in the gallbladder and the biliary tree. So it means the air, the gaseous, that reflexes into the gallbladder, and there is a presence of gaseous, and that will be seen on the X-ray. So have you got the point?
Yes.
Perfect. So what's your answer? Is there this lodge? So what's the question? The patient gallstone has most likely lodged in which of the following site? So it will lodge into the ileocecal hair, ileum, and cecum junction. I am right.
Yes, sir.
Perfect. So cystic duct, duodenum, ileum, and jejunum. So what's your answer? Anyone?
Is it the
Option
ilium?
B.
It is simple. There
I
is
think it's alien.
perfect. There is junction between ileum and cecum. There is an option of cecum, so we will go to the ileum. If there is an option present, that is a cecum. For example, there is another option that F and it is cecum. So what will we do? It will be this or it will be this. What do you think?
D. Ilium.
Perfect. The answer will be ileum as well, because whenever you have a, this is your ascending colon, this is your cecum, and here is your ileocecal junction, or here this is the ileum. So the stone will lodge over here. It is the part of the ileum, not the cecum. Have you got the concept?
Yes.
Perfect. Okay,
Yes, sir.
perfect. So it is the ileum, there is a corruption over here, and that will move our head. Okay. And a new volunteer. We have done with Dr. Rahul, we have done with Dr. Mahnoor. I want a new volunteers. Hurry
This
up.
patient's ulcer has most likely penetrated
Could
which
you
of the
please
following arteries?
could you please tell me your name?
Yeah, Sarah.
Okay, Dr. Sarah, go ahead.
Okay, thank you. So, this patient's ulcer has most likely penetrated which of the following arteries? A
Mm-hmm.
52-year-old man is brought to the emergency department due to repeated vomiting
Mm-hmm.
that began 2 hours ago. His
Mm-hmm.
vomit is dark brown and has a granular consistency. The
Mm-hmm.
patient has a history of dyspepsia, for which he takes over the counter antacids as needed, and degenerative knee arthritis, for which he takes naproxen regularly.
Mhm.
He drinks 2 to 3 beers daily.
Okay.
Temperature is 36.7
Mhm.
degree. Blood pressure is 114 by 62. Pulse is 102 and respiration are 14. Physical
Mhm.
examination reveals mild epigastric tenderness with no rebound or gardening.
Mhm.
Hemoglobin is 9 gram per deciliter. Endoscopy shows a deep bleeding ulcer on the posterior wall of the duodenal bulb. The
Mhm.
patient ulcer has most likely penetrated which of the following arteries?
So I have yesterday discussed detail of the foregut blood supply. That is a celiac trunk. So, do you have clear the concept of the celiac trunk and where it is positioned, or do I explain it now? Wait a
Please
minute. Let
explain.
Okay. So basically, this is the posterior wall of the bleeding ulcer on the posterior wall of duodenal bulb, and patient have a penetration of which of the following artery. Okay. So now discuss what is going on and which artery is going over here. Okay. Let's discuss it. This is your esophagus. Okay. This is your stomach. This is your first part, second part, third part, fourth part. Okay. And this is your pancreas over here. And this is your amphilophoid. Have you got the point? This is the abdominal aorta coming. Abdominal aorta over here. Over here, and it gone down, and it is it over here and here, like this. Okay. And here is the branch that is called a celiac trunk over here. Celiac trunk. Okay. So first branch, anyone?
Celiac trunk.
This is celiac trunk. First branch of celiac trunk here.
Left gastric.
Left gastric artery.
Perfect. Left gastric artery over here. This supplies the lesser curvature over here. Have you got the point? And it also supplies to the distal part of esophagus, and it's like that. Have you got the point? Now, what's this artery that go behind the stomach?
Splenic artery. Means
Splenic artery.
Okay, perfect. So this artery supply the spleen. Okay, this part of the duodenum. This is called short gastric, and this is splenic artery. Okay, and another branch that supply this. What's this called?
Left
Left
gastroepiploic artery.
gastro-
Yes, epiploic. Perfect. That's the point. Now, what's this artery? Common hepatic. Okay, this is divided into two arteries. Number one, proper hepatic. This branch proper hepatic. Okay, and this is
Gastric.
gastric. Perfect. This proper hepatic goes up and give a branch. This is a left gastric. So this is the right gastric, and it supplies the remaining anastomose with a left gastric over here. Okay, and then this proper hepatic divided into right and left hepatic, right hepatic and left hepatic. Okay, this gastroduodenal artery goes behind the first part of the duodenum. Okay, and here it supplies the branch that is called supraduodenal, and supplies the first part of the duodenum, and this go behind this duodenum and supplies the this part of the anastomosis with here, and this is called
Right gastroepiploic.
right gastroepiploic. So what's your answer over here? So anyone can tell me what's the answer over here? There is a problem going on here. This is your bulb problem going on over here. Okay. So if there is a laceration over here, this is the point of laceration over here. So which of the following artery will be the cause of this bleeding?
Gastroduodenal.
Perfect. I think you have all cleared the anatomical position of the gastroduodenum. Okay. This is the answer. Where is the common hepatic? Common hepatic is present over here. Okay, where is the left gastric epiploic? Left gastric epiploic is present over here. Where is the right gastric? Right gastric is present over here. Where is splenic? Splenic is present over here. Where is superior mesenteric? Superior mesenteric is present over here, and it passes interior to the third part of duodenum. Yesterday we have discussed the question topic. Then whenever there is a patient present with anorexia, weight loss, very heavy weight loss, and no eating disorder, and there will be decreased intra-abdominal fat. So this superior mesenteric put a pressure on the third part of duodenum, and there will be obstruction. I have another question portion. Whenever there is a tumor over here, that will push the superior mesenteric artery, and have you got the point? Whenever the third part of duodenum tumor or any compression over here, that will compresses the superior mesenteric artery. Superior mesenteric artery. Have you got the concept? No, I think you have got your answer. Everyone have clear?
Yes.
Yes.
Perfect, perfect. So we have done with Dr. Rahul, Dr. Manur, Dr. Sara, and who is remaining? Go ahead. Any new volunteers?
I can read, doctor. It's
What
Iman.
is your what's your good name?
Iman.
Oh, Dr. Iman, go ahead. Perfect.
Okay. So, which of the following pathophysiological changes most likely contributed to this patient's current condition? A
Yeah.
54-year-old man come to the office due to several months of heartburn, acid
Mhm.
regurgitation, and dysphagia. He
Yeah.
has taken antacids and over-the-counter medications without relief. Medical history includes hypertension and hyperlipidemia. The patient doesn't use tobacco, alcohol, or illicit drugs. Vital signs are within normal limits. BMI 32. Physical examination is unremarkable. Upright chest X-ray shows an opacity with an air fluid level behind the heart. Subsequent barium swallow reveals the proximal stomach herniation through the esophageal hiatus.
All
Which of the
right.
following pathophysiological changes most likely contributed to this patient's current condition?
Oh, yeah, perfect. A very simple question. The patient is asking, upright checks show a air fluid, behind the heart. What does it mean? It's meaning the gastric content and the gastric and the either intestine or the stomach has in the thorax. Okay, so in the subsequent bearing swelling, this proximal stomach is herniating in the esophagus. It is you have diagnosed it is the hiatal hernia or esophageal hernia. Okay, so which of the following pathophysiology changes is more likely to contribute in the current condition? Cephaloid migration of the squamous junction with the fixed gastrointestinal junction. This is what we think going on. Cephaloid migration of the squamocolumnar junction with a fixed gastrointestinal junction. I think it is having a metaplasia going on.
Is it Barrett's esophagus?
Yeah, it is a Barrettophagus that is going on over here. So I think there is no any history of the Barrettophagus or esophagus over here. So basically, the question is asking about this proximal stomach is herniating into the stomach. So what is the cause? So let's discuss briefly about the uh, hiatal hernia.
Is it hernia, right?
Yeah, let's discuss about the hernia, what's going on in hernia. So we will discuss the types of hernia and the a little anatomy. Okay. that you have clear about what is hernia going on. For example, this is your esophagus, okay, and this esophagus is passing through what's this? Can anyone tell me what's this?
Diaphragm.
Perfect. This is diaphragm. This is esophagus, and this is you started with the stomach started over here. Now, there is a thin membrane that is present over here and over here. This is the normal anatomy of the gastroesophageal junction, and there is a membrane that is present on the that surround the gastroesophageal junction. This membrane is called the phrenoesophageal membrane. Have you got your normal anatomy? Now let's discuss what's happening in this condition. Okay, there are basically the two type of hernia. Number one hernia. Whenever this membrane relaxes or loses tone, so that this part of the stomach will be goes into the relaxed stage. Like you will be having like this is this will be in your stomach. Okay, you got the point. And this type of hernia is called sliding hernia. Sliding of the gastric through the phrenoesophageal membrane without forming a defect in the diaphragm. This is number one type. Number second type. If there is a defect that is in the diaphragm and this part of stomach has entered in the have got the point. So this type of hernia is called paraesophageal hernia. It is with esophagus, so it is paraesophageal hernia, and this is a sliding hernia that will through the paraesophageal membrane. So there is a defect in this case, and there is a relaxation of the gastroesophageal junction. Have you got the point? So, what is the how will it present our hair? Okay, basically, this the first type of sliding hernia. You will be having stress, like you will be having a severe vomiting and cough that will lead to the relaxation of the gastroesophageal junction. So that will lead to a sliding hernia. And if there is a paraesophageal hernia, that is a very rare cause, and there will be the defect in the diaphragm, and it will lead to whenever this will compresses the lung, and there will be the distresses and any uh, thing present with it. Okay, have you got the point? So what's the question is asking about? Question is asking about whenever we swallow. Feeding on chest axis to opacity or right lung, execution berries will reveal a proximal stomach herniated through the esophageal head. Which of the following pathology would most likely contribute to extirpation? Let's discuss. Well, let's come to the question. Seaford migration of squamopepikular junction. It means they're asking that this epithelial has changed and there are no abnormality to the gastroesophageal junction. So it's a ballotosophagus. Okay, so it is incorrect. There is no asking. So circumferential laxity of a paraesophageal membrane. What do you think?
Yes, this can be the cause. That's
This can be the cause. That's the perfect. Okay. So, what is diaphragmatic muscle paralysis due to C3 and C motor? What do you think over here?
What's the phrenic nerve injury?
It is the phrenic nerve injury, but the patient will be asymptomatic. Why? The diaphragm is not working properly, but there is another.
Vagus
mm,
nerve supply.
Intercostal nerve.
no, no, no. If the diaphragm is not working properly, okay, so this work will be taken by the extra, the intra-abdominal continent. Sorry, uh,
Thoracic,
the other respiratory muscle will help in it.
intrathoracic.
Yeah, endarothoracic muscle will help in the relaxation and the contraction of the lung. It will help in, but this patient will not present with the history of the proximal herniation through the esophagus. Okay, failure of the posterolateral diaphragmatic foramen to fuse. It is a Bojanic hernia. It is congenital hernia. Leave it. It's not. This is not the cause. We will discuss it later. And what is this? A herniation of the abdominal continent through omental foramen. It is also not the cause. Basically, omental foramen is a foramen of which to cause intra-abdominal hernia through the lesser sac. And lesser sac hernia are very rare. The most common hernia in the patient will be having a heartburn, regurgitation, and dysphagia. This patient having a GERD, and that will lead to the antacid having the any history. So it means the patient is having either a sliding hernia, that is this type, and said paraesophageal hernia. So there is no any differential point between. They are not asking about the types, but they are asking about what the pathophysiology of this hiatal hernia. So it is basically a sliding type, and there is a defect in the perisphegeal membrane. Okay.
Yes.
So, sir, the failure of the parastrophical diaphragmatic foramen to fuse is for, it's for like diaphragm, for diaphragmatic hernia in the
Mhm.
case of like embryological defects, right?
Yeah. It is
So,
associated with two more things. There will be, it is present in neonates.
okay.
Okay, and it will be diagnosed prenatally.
Oh,
Second,
okay.
and there will be having a lung hypoplasia as well.
Hmm.
Okay, and
So,
plus neonatal distress.
oh,
Okay,
okay. Okay. So
this
they
is,
should give a, like an X-ray or something if
yeah,
it's
that's
for
it. So
that was
it,
the answer.
yeah, perfect. So it is a old age, old
Okay.
age. Okay,
Okay, so thank you.
thank you very much. So what's your good name, doctor?
Deal.
You can proceed. We've done Dr.
Next
Rahul.
question.
Okay,
Okay.
Doctor. Okay, Dr. Rahul. We have done with Dr. Rahul. We have done with Dr. Manur. We have done with Dr. Sara. We have done with, I not remember the fourth one. And I discussed the fifth one.
Okay, sir.
What?
Thank you.
Okay.
Uh, the ulcer most likely penetrated which of the following arteries? A 75-year-old man is brought to the emergency department due to acute onset profuse vomiting of large amounts of bright red blood.
Mm-hmm.
He has had intermittent dull epigastric pain for the last 3 months. Medical history is significant for chronic obstructive pulmonary disease with
Mm-hmm.
multiple exacerbations and lumbar spinal stenosis.
Mm-hmm.
The patient has smoked one pack of cigarettes daily
Mm-hmm.
for 40 years. Blood pressure is 70/40 and pulse is 120. Examination shows epigastric tenderness. The patient dies an hour after admission despite resuscitation efforts.
Mm-hmm.
Autopsy shows a deep peptic ulcer localized proximally on the lesser curvature of the stomach. The
Perfect.
ulcer most likely penetrated which of the following arteries?
So I think you have to do by yourself. This is lesser curvature. So which artist apply this part?
Yes.
Come on. Everybody uh, should know the
Left
answer.
gastric.
Left gastric?
Perfect. I think everyone have cleared this anatomy. That this is the type of the left gastric. Okay, have
Okay,
cleared your
sir.
concept.
Yes, sir.
That's perfect. That is the left gastric. Okay,
Okay.
I think there's no need of any explanation. I've explained 2 to 3 times. Okay. Oh, perfect.
Okay.
So, any new volunteer?
Yes,
What's your good name?
Dr. Peter.
Dr. Safira. Okay, Dr. Safira, go
No,
ahead.
Peter, Peter.
Dr. Fisa.
Mhm. Peter, Peter.
Peace. Okay, okay, Dr. Pisa, go ahead. Okay, doctor, go ahead.
These patient symptoms are most likely related to the pathology involving which of the following structures.
Okay,
A
right, perfect.
74-year-old man comes to the office due to dysphagia. The
Mm-hmm.
patient says that it feels good. It feels like food has been getting stuck into his throat over the last month. He
Mm-hmm.
has changed his diet to accommodate his symptoms and now consumes only liquid foods. The patient has a long history of postprandial heartburn that sometimes awakens him from sleep. He has treated his heartburn with over-the-counter antacids, but usually only has partial relief. A thoracic CT image near the level of the aortic arch is shown below. So these
Mm-hmm.
patient symptoms are most likely related to the pathology involving which of the following structures.
So what do you think?
The
Um,
the symptoms are of the eclasia, right?
yeah,
So, can you let interpret the CT scan, then
Yeah.
we go ahead of the cause, so that you can know
okay.
better what's is present in
Mm.
the CT scan. Okay, what's this? The first important thing to go to the easiest path. What is this?
That's the spinal cord.
Okay, that's spinal cord. Okay, what's C? There is air present. It is a blackish. So it means it is
Trachea.
perfect.
It's a
It is. Is it no? In esophagus, it will be not
Ah,
show the dark. The dark
oh,
color mean this one and this one. This mean that these both two have containing the air. So this is lung and this is lung and this is trachea. The C option is trachea.
ah,
Okay,
okay. Same, same. Okay, sir. Thank you.
welcome. So option C is your trachea.
Mm.
The one general rule for the artery and vein, I would want to tell you, this is your right side and this is your left side. Most of the anatomies of the vein is toward the right side. Right will be the vein almost 90% in 90% cases, and left there will be the artery. Okay, the city's thoracic level. Oh, okay. It's the at the level of aortic arch. Okay. So what's this? A B C D E F. What is F? It is F. It is it toward the right side. So right side mean vein. So it will be.
Inferior vena cava.
It is a superior vena cava.
Superior or inferior?
It is superior vena cava over here. F will be your vein. That is your superior vena cava. Okay. What's your G? So G will be your toward the left side. So left side mean artery, and this artery is your ascending aorta. It is at the level of aortic arch, so it is ascending aorta. What's E over here? It is at the level of, for example, this is your ascending arch and descending. It is at the level of this. Okay, CT scan it at level of aortic arch. So at arch there will be having up. This is your E is your pulmonary artery. Pulmonary artery. Okay, E. What's the D? D is too much small. It is very confusing. It is a zygous vein over here. And what's the A over here? So it is F. The G is ascending iota. So the A will be your
Descending.
yeah, it will be your descending then. Okay, what's the B? This is B is esophagus. Okay, have you got the point?
Yes.
Okay. So the trachea, esophagus, D is azygous vein. Not remember, it is not that high yield point, but remember artery, vein, esophagus, and trachea. That three are more to know where this location in the CT scan. Trachea, esophagus, and trachea, esophagus, pulmonary, sorry, the superior vena cava, inferior vena cava, and descending aorta. Okay, aorta, trachea, esophagus, and these things. So, what's the problem is going on? The patient is having a dysphagia. So, dysphagia is due to it is
Obstruction.
about no, it is due to something that lead the cause. The patient symptom are most likely pathology of which of the following structure? It is a very simple question.
B.
It is perfect. B. It is pathology on trachea. No, any work with the superior vena cava. No, 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 no. It's with esophagus. Have you got the concept?
Yes.
So, which of patients? So which is option is right?
B.
Perfect. B. So I think everybody have got the concept of the CT scan. So you know the reading and you know the superficial reading, like you know the trachea, esophagus, aorta, and
So,
the
what is the structure D?
Acyclovir.
D. D is zygous when it is not that high yield. It is
Okay.
not that high yield. You have to remember these four structure: esophagus, trachea, and aortas and vein. Okay.
Okay.
Thank you very much.
So it's just simple question, just where this food is stuck in the esophagus.
Yeah, it was very simple. What is the cause of this feature? Simple.
Oh, okay,
That is due to the esophagus custom. Yeah.
okay.
So, any new volunteers?
Yeah.
Hmm.
Before beginning the patient treatment, which of the following structure labeled on the image is expected to have increased pressure? A 53-year-old man who has seen a physician in year presents to the office complaining of abdominal distension. He
Hmm.
states, last month my stomach started to swell and it hasn't gotten any better. He
Hmm.
has other medical problems. The patient admits to drinking 10 to 12 beers a day for the last 20 years. His
Hmm.
temperature is 36.798, blood pressure is 116/72, pulse is 78, and respirations are 20 per minute. On examination, his abdomen is distended with engorged para-umbilical veins. There is also palmar erythema and spider angiomas are present. You
Okay.
decide to place him on low salt diet and start therapy with furosemide and spironolactone with subsequent improvement of his abdominal distension.
Hmm.
Before beginning this treatment, which of the following structures show expected to have increased pressure?
What do you think is going on, especially?
It's liver cirrhosis is going on in the presentation actually.
Yeah, it is liver cirrhosis. Perfect. So basically, in liver cirrhosis, you will. It is a typical case of liver cirrhosis in which you will be having abdominal distension. Okay, abdominal distension is due to the liver. Any swallowing, there will be having the history of the beer, and we will be having a notch peri-umbilical vein, palmar erythema, spider angiomas are typically with the liver cirrhosis. So just know what's the liver cirrhosis that is due to the induced alcohol-induced liver cirrhosis. Okay. So just remember, we will discuss the pathology of the liver cirrhosis whenever we start the pathology section. But what they are asking about? They are asking before beginning this patient treatment, which of the following structures labeled on the image below is suspected to have high increased pressure? It is basically the high back pressure they are asking about. Okay.
Yeah, we have portal hypertension in the liver cirrhosis, right?
Yeah, portal hypertension. That's the perfect. That we will be having a portal hypertension, and that will lead to the back pressure into the esophageal. You will be having a bleeding in esophageal varices. You will be bleeding in the stomach. You will be backflow petal edema, and you will be having everything in that case. Okay. So, could you explain which structure? Let's discuss the CT scan. So, wait, they are asking. Okay, perfect. So, what's this? It is not blackish. It is a whitish colorish. What do you think?
Liver.
Perfect.
Liver.
That's liver. Okay. What's this?
Spleen.
Spleen. This is spleen. Perfect. Okay.
Okay, sir.
Yeah, right. Let's go to the point. What's C? What's P over here? And what's A?
A is the aorta.
Aorta, abdominal aorta.
Perfect. That is abdominal aorta, and it is toward A is toward
Right. Sorry, left.
Left side.
Left side.
toward the left side, so it is aorta, and
Mm.
P is toward the
Right.
Right
Portal,
right
side.
side. It will be
portal vein,
Total vein.
portal vein.
sorry. It wait a minute. I want to just clear one thing. Which that is near to the spinal cord, the vertebra, like A and B. So these are the major arteries, like aorta and inferior vena cava. So A is
Oh,
abdominal aorta, okay, that is near to the vertebra, and B is the near to the vertebra, and that will be your
inferior vena,
inferior
vena
vena cava.
cava, vena inferior.
Yeah.
Inferior vena cava. I think you have forgot the inferior vena cava. You have to leave the inferior vena cava.
Yes.
Okay, perfect. So what's C? So that's your answer.
That is the
Yeah.
That's the
portal.
portal.
Yeah,
Vein.
that is the
That is
portal.
portal vein. And what's this D? This
Cilia.
supply perfect.
Mm.
This supplies this, and this supplies the splenic, and this is
Electron.
Celiac
celiac.
trunk.
Perfect. Have you got the concept of a little bit about the CT scan? How you will go with the CT scan?
Yes, sir. Your explanation was very helpful. Thank you so
Okay,
much.
thank you very much. So I think option C is correct over here. So you will be for attention of the portal vein. Okay.
Okay, sir.
So option B is correct, right?
Yes, sir.
Okay, perfect.
So B
Sorry.
or C? C.
C,
C,
right?
sorry. Oh, C, sorry. So I was talking about C. It is a portal hypertension. Okay.
Yeah.
It's C. Okay. Not B. I
Okay,
was
sir.
confused a bit. That's weird. Yeah. Another any volunteer, new volunteer. I want a new volunteers.
I can go. Um,
What's your good name?
Shrapya.
Shrabya. Oh, Dr. Shrabya. Okay, go ahead.
Okay. Which of the following structures is the most likely source of this patient's bleeding? A 23-year-old man is brought to the emergency department after he was stabbed in the right upper quadrant of the abdomen. His blood pressure is 70 over 42, pulse is 135, respiration is 26, pulse oximetry shows oxygen saturation of 95% on room air. Physical examination shows a stab wound 2 cm inferior to the right costal margin. The patient's abdomen is firm and distended. Focused assessment with sonography for trauma fast is positive for blood in the right upper quadrant. He is taken for immediate laparotomy and approximately 1 liter of blood is evacuated from the peritoneal cavity. Brisk non-pulsatile bleeding is seen emanating from behind the liver. The surgeon occludes the hepatoduodenal ligament, but the
Hmm?
patient continues to hemorrhage. Which of the following structures is the most likely source of this patient bleeding?
So let's discuss what structure passes through this hepatoduodenal ligament. Okay. I think we have discussed it, but I haven't discussed hepatoduodenal ligament. Okay. a liver over here, right? So there is a ligament that is present over the lesser omentum, like this, gastro, gastro, hepatogastric ligament, lesser omentum, and other type is hepatoduodenal, hepatoduodenal, and hepatogastric. Two ligament present over here that support in that present in the lesser omentum. Lesser omentum has divided into two parts: hepatoduodenal, hepatogastric. Okay, so what structure passes over here in the hepatoduodenal ligament? Okay, let's discuss it. I've discussed it. What's which artery is passing through it?
Hepatic artery.
Perfect. Hepatic artery passes through this aorta. Like we will be having a common hepatic artery and common hepatic artery divided into two artery, the proper hepatic artery and the gastroduodenal artery. That common hepatic artery give rise to the right gastric artery and right gastric, and then the proper hepatic goes into right hepatic and left hepatic. And there is one branch from his to right hepatic. This branch is called a cystic artery. So cystic artery is basically supplies the gallbladder. This is the cystic artery is a branch of right hepatic artery. Okay, and this is a left hepatic artery. Okay, you got the point. So first is proper hepatic artery or hepatic artery. Number one, the structure that is present in it is hepatic artery or a proper hepatic artery. Number second, let's talk about the second one. Second one that is present is here, that is a portal vein. We will discuss the portal vein tributaries, okay, in detail. Like you will be, this is a portal vein coming over here, and beneath this, and this is portal vein come on over here. Okay, a splenic vein and inferior mesenteric vein when combined, it lead to the portal vein. It is behind the duodenum. Okay, so the second structure that passes is the portal vein. Okay, we go to the third structure. So third structure is your the duct that passes through
Bile duct.
bile duct, common bile duct. But left bile duct, common, then it will common bile duct, and that drain into here. Okay. So these structures are present in the hepatoduodenal ligament. These structures are present in the hepatoduodenal ligament. Okay, common bile duct. So whenever this pinching maneuver is called a Pringle maneuver. Whenever we block this hepatoduodenal ligament over here, so this is called, it is just to remember the name is the Pringle maneuver. Okay, so that's not high yield to remember, but to remember which structure passes to the hepatoduodenal ligament. That's your point. Hepatic artery or common proper hepatic artery, portal vein, and common bile duct. Okay. Now let's come to the MCQs which they are talking. Okay. Whenever I block this duodenal and this hepatoduodenal ligament, so you mean I block the common bile duct?
Hepatic artery.
That is blocked. Cystic artery over here is blocked or not due to this?
Yes.
That is
Yes.
blocked. Hepatic artery block. Portal vein blocked. So which of the following structure is most likely the source of this bleeding on the basis of exclusion?
Inferior vena cava.
IVC.
IVC, perfect. So I have blocked this. So I have blocked this artery, right hepatic artery, left hepatic artery, portal vein, common bile duct, proper hepatic artery, portal vein, everything I have blocked. But the remaining is inferior vena cava. That bleeding is due to inferior vena cava. Simple on the basis of exclusion. Just in this question, remember which structure passes to hepatoduodenal ligament. Okay. The main concept over this question is that to remember which structure passes the part of root in the ligament. When you know all of these, then you can directly go on the basis of exclusion. You will correct your answer. Okay?
Yes.
Perfect. Any new volunteers? Any volunteer? I want to.
Sir, I can.
What's your good name?
Kaivalya.
Okay, doctor, go ahead.
In the event of interruption of blood flow secondary to the arterial occlusion, which of
Mhm.
the following organ would be the least vulnerable to the infarction?
Yeah.
A 50 years old man comes to cardiology clinic because of fatigue, palpitation, exertional dyspnea over the last several weeks. On the physical examination, his heart rate is irregular and measure 122 beats per minute, while his blood pressure is 110 by 70. The patient undergo further workup, including ECG, radiographical studies, and laboratory studies. His ECG shows atrial fibrillation, and transesophageal echocardiography reveals a thrombus in the left atrium, in left dilated atrium.
Mhm.
In the event of the interruption of blood flow secondary to the arterial occlusion, which of the following organ would be the least vulnerable to the infarction?
What the question is asking about?
Did I
Wait,
but
wait a minute. Wait a minute. Least vulnerable infarction mean that the organ that they are asking they are having a dual supply.
Yes.
Simple.
Which of
Okay.
the have the dual supply?
Okay. So spleen, brain, kidney, liver, and heart. So what do you think is your correct option? Heart is also a single artery supply, the coronary artery. Kidney is an end artery, not that water myocardium. Brain is also the carotid artery is also not having a this damage, but if this patient having damage whenever there is ischemia within a 5 minutes, the patient will go into the ischemia, complete ischemia. Okay, they're irreversible damage, and whenever the heart, it will take almost 30 minutes to become to myocardial fraction that lead. So what do you think? It will kidney. It is also due to the renal artery stenosis that activated is the ROS system and everything like that. And spleen is
The
also
liver.
supplied. Sorry.
Liver?
The liver.
Yeah,
Dual
perfect. So
supply.
basically the liver is supplied by the two artery. One is the minor and one is the major. The major artery is your proper hepatic artery. The proper hepatic artery divided into hepatic artery. The common hepatic artery divided into proper hepatic artery and gastroduodenal artery. The proper hepatic artery goes and supplies the liver. This is your first and major arterial supply of the liver. And the second,
Yeah.
and that is through a accessory vessel that are from the inferior phrenic vessel. Intercostal arteries are important, and adrenal arteries, and many other arteries supplying the liver through very small vessels. Okay, so liver is having a dual supply, so this lead to the least infarction in this. And okay,
Portal vein. So
sorry,
the portal vein also
also the portal
supplies
vein.
the.
Okay, yeah, the portal vein, the most important thing. Also, the portal vein also supplies. Yeah, perfect. I forgot
Sir,
that.
what about spleen?
Spleen is not. Spleen is single artery supply, and if whenever we block this, it will spleen is also a single artery. It's not that.
Oh,
It
okay.
also due to the infarction, and it is a splenic artery that is an artery, an artery.
Hmm.
So, can you tell me, splenic artery is a branch of
Celiac trunk.
what?
Celiac trunk.
What you have completed your in artery. Okay,
Okay.
you got your answer. It's liver square. Okay, now, okay, okay. Any new volunteers?
So before we proceed, sir, could you please once more go over the atrial blood supply to the liver, please?
The major one?
Yeah, the major ones, sir.
Okay, perfect. Basically, is esophagus, okay,
Okay,
stomach, and first part of duodenum. Okay,
okay,
aorta is coming on. Sorry, aorta is coming down like this and this. Okay,
okay,
here is celiac trunk. Celiac trunk supply give three branches: one, two, and three. Okay,
okay,
left gastric, splenic, and common hepatic. The common hepatic divide into two: proper hepatic and gastroduodenal. The gastroduodenal go beneath the first part of duodenal, and here is give a branch that is supraduodenal, and this undergo down and gas and supply this part. This is called right gastrocolic artery. Okay, the proper
okay,
hepatic goes up and give a branch that is a right gastric. This is the left gastric. It supply this part, so right gastric come over here and supply this and anastomosis with the left gastric. Okay. This
okay,
proper hepatic goes up and divided into two: left hepatic and right hepatic. This enters the liver, okay, and supply the whole parenchyma of liver. And this also supply a gallbladder present over here. So this give a small branch. This is called a cystic
okay.
artery, and cystic artery is a branch of right hepatic
Right,
artery. Okay,
okay,
have you got the
okay.
concept?
Yes, sir, got it. Thank you so much.
You are welcome. So let's simplify it. Endoscopy reveal esophageal varices. The current condition is led to chronic shunting through which of the following veins? There's a, for example, this is your esophagus, stomach, okay, and
Okay,
bleeding is over here. Bleeding esophagus over here, okay. So what do
okay.
you think? The patient is having. Can someone go to the stem and
I
you
can,
will?
Yes.
I a
Yeah.
52-year-old man is brought to
What's
the
your good name? What's your good name?
Mahanur.
Okay. Is no volunteer present? Okay.
Well,
So,
yeah,
yeah.
okay.
And a new volunteer? Okay.
I can do it if there's nobody else.
Okay. What's your good name?
Dale.
Okay. Go ahead, doctor.
A 52-year-old man is
Hmm.
brought to the emergency department for hematemesis that began an hour earlier. He has regularly consumed large amounts of alcohol for the last 20 years and has been hospitalized numerous times due to ethanol intoxication. Temperature is 36.7, blood pressure is 90 over 60, pulse is 106, respirations are 22. Physical
Hmm.
examination shows jaundice and scleral icterus. Examination of the abdomen reveals a palpable spleen and a moderate ascites. Endoscopy reveals bleeding esophageal varices. This patient's current condition most likely resulted from chronic shunting of blood through which of the following veins?
What do you think? So basically, bleeding is over here.
Well, again, it's like a patient with cirrhosis having
Yeah.
esophageal varices.
Yeah.
So,
What do you think?
uh,
Can we? Why not to explain the arterial supply as well, so that you can clear your venous supply? But it's talking about, I think, vein. So let's discuss the vein. We have done with arterial supply. Let's discuss the vein. Okay.
okay,
So
okay,
that you have a clear concept of your arterial and blood arterial and both the arterial and the venous system. Okay. So for
sure.
example, yeah, this is your esophagus. Okay. Stomach over here. Okay.
Okay.
First part, second part, and third part. Okay. Spleen over here, liver over here. Okay, let's discuss the point that we have to remain in this concept. Okay. Now, here's the artery that's go above the stomach and enter over here. This is called your superior mesenteric artery. Oh, sorry, vein. Superior mesenteric vein. Okay?
Okay, sir.
Okay. Now, what are the tributaries of the superior mesenteric vein? This supplies came over from this part. This is your the artery and vein having same name. Okay, this is your right gastroepiploic vein.
Okay.
Okay, like an artery, but just
Wait.
change the name vein. Okay,
Okay.
okay, perfect. It drain into this. Okay, into superior and cava. And one most important thing, there is a pancreatoduodenal artery. Okay, that supply this area. And also renal superior. This is your pancreatoduodenal artery. Duodenal. Okay, just it's having a branch, inferior branch and posterior branch. It leave the anterior and posterior. Just remember that superior and training have tributaries, right epiploic gastric artery and pancreatoduodenal artery. Okay, this drain into the superior mesenteric artery. Now,
Artery or vein, sir?
vein shape. I am
Okay.
again
Oh,
confusing the artery. Let
okay.
vein. It's
Okay.
vein.
Okay.
Okay, it's vein. Okay. Now,
Okay.
is the splenic vein. This is your splenic vein. So this is your which vein? This is right.
Left gastro.
Your part vein. This
Left
is
gastric.
left left
Gastro.
gastroepiploic vein that drain into the splenic vein. Okay, and another tributaries over here that also drain into the splenic vein, and this is called your left gastric, same name as artery. Okay, this go
Okay.
under the stomach and join with the superior mesenteric artery. Okay, when this join over here, so the name changes.
Portal vein.
Perfect. This is called your portal vein. Okay, superior mesenteric vein, splenic vein. When joined, the name changes. Portal vein. Okay, now where there is this also there is a lesser curvature over here. So lesser curvature also give enter into this. This is called your left gastric. And also there is a right gastric directly present over here. So this is your right gastric. It drain into the superior your the portal vein. Oh, sorry. It is your hepatic portal vein. Okay. So in portal vein, left gastric and right gastric drain into your portal vein over here, and this drain over here. Left gastric and right gastric. You got the point. And this divided into your hepatic vein, like this and like this. Okay. And this supply your this go to your lung parenchyma. I think we have got the concept over here. Okay. And this is
Yeah.
also branches or present into distal esophageal. This drain into left gastric, and left gastric drain into the hepatic
Or
portal. Okay, have you got the concept?
Mhm.
Yeah. So the endoscopy revealed bleeding esophageal varices, the patient current condition most likely resulting from chronic shunting of blood through which of the following vein? So esophagus is over here. So which artery is present over here? A vein, sorry.
Left,
Sorry?
left gastric.
Left.
Perfect. Left gastric is present over here. Okay. So paraumbilical is present on the superior surface of the interior abdominal wall. It's not that. Right gastroepiploic is present over here. It is tributaries of the superior mesenteric vein. Splenic vein is also the a drain into the superior mesenteric vein, and then the name changes portal vein, and superficial epigastric is present also on the superficial surface. So the main concept was here to remember the venous supplies or venous tributaries of this stomach and foregut. Okay, have you got the concept?
yes, doctor. Thank you.
Okay, perfect. You are welcome. I think we have got the answer for left gastric is correct, right?
Yeah.
Yes, sir.
Okay, perfect. So let's move forward. Oh, yeah. Okay. So any volunteer, any new volunteer? Any new volunteer? I wanna join a new volunteer.
Can I read it, sir?
Okay, go ahead. What's your good name?
Dr. Archana.
Dr. Archana. Yeah. Go ahead,
And
doctor.
a 67-year-old man comes to the emergency department due to progressive fever and lethargy. The patient has also had severe right shoulder and abdominal pain, nausea, and vomiting for the past 2 days. He had an appendectomy during childhood and a pacemaker placed 10 years ago for symptomatic sinus bradycardia. He has no other medical problems and takes no medications. The patient does not, sorry, doctor.
Yeah, go ahead. Go ahead.
The patient does not use tobacco but drinks an occasional beer. Temperature is 38.4 Celsius, blood pressure is 80 over 50, and pulse is 120 per minute and regular. Abdominal examination shows generalized tenderness with rebound tenderness. Right shoulder examination is normal. Upright chest X-ray is shown below.
What do you think?
Here, right side pacemaker and
Yeah, pacemaker is present.
yeah,
Could you
Is
note
air under diaphragm?
what? What is here?
Pleural
There is
effusion.
No,
air
no, no.
here.
Yeah, pleural effusion is also
Pleural
present because
effusion.
yeah,
The
also
fluid.
pleural effusion.
Fluid
Wait.
exhalation.
Yeah, wait a
Is
minute.
air under
Let's
diaphragm.
discuss it. Wait a minute. So whenever there is this is your lung, okay,
Mm-hmm.
like this. So if there is a blunting of this costophrenic angle, so it means there is a pleural effusion present. Okay.
Okay, sir.
But the point I'm emphasizing on it, what is this? A line of white line, and under the white line there is a blackish line under this.
Air fluid level.
air under the diaphragm.
Yeah, it is. This is no air, no air fluid. It is basically the air under the diaphragm. This is the diaphragm, so it is under the diaphragm. The air under the diaphragm. So
Oh,
basically, this is the pneumoperitoneum.
pneumoperitoneum.
Pneumoperitoneum. Yeah, it is basically yeah. So a right shoulder examination is normal and regular, and there is a medical history. Temperature is also patient is having going to the shock. So shock, first see the heart rate. It is high.
Hi.
It is also going to the decreased blood pressure. The patient is in shock. Okay, So abdominal examination showed generalized tenderness with rebound tenderness. So many for students will be directly going to the appendicitis and any inflammation going on. So patient is having a severe right shoulder and abdominal pain.
That's referred pain due to chronic neuro.
Yeah, it is the referred pain. So what is your diagnosis over here?
That's actually an ulcer perforation.
Perforation, right? And what about your cholecystitis? The cholecystitis pain also referred to your shoulder.
Hmm.
But do not see the pneumoperitoneum in that, no?
Perfect. So in your cholecystitis, okay, there is a no any chances of the
Pneumo-
pneumoperitoneum over here.
pneumoperitoneum.
Have you got the point? The scenario is same as cholecystitis, but the main point is to you have to look the X-ray. In the X-ray, there is no free air under the diaphragm. Okay, so there is a perforation that perforation lead to gas under the diaphragm. Okay, so let's come to the question. So what they are? Which of the following is mostly like cause of this patient? Yeah. So I have excluded this cholecystitis because no free air under diaphragm. Am I right?
Yes.
Acute pancreatitis pain is referred toward the back.
Yeah.
Yeah.
Okay, and nephrolithiasis is having a typically pain that is a colicky pain, flank pain that is present on the flank pain, like groin. So there should be a X-ray of a KUB, kidney ureter bladder. So in which we will diagnose it is a radiolucent or radiopaque stone. So it is not the X-ray of KUB, X-ray of chest X. So I also excluded this. Small bowel obstruction. Is there any distension?
No.
No.
Any
No.
vomiting?
Not at all.
No.
Okay, perfect. So
That's a
on the
topic
base,
we discuss.
sorry,
Yep.
yeah, on the basis of exclusion, we have taken this answer.
Perfect. Yeah.
I have clear your concept.
Yes.
Yes.
Perfect. Just remember for now, it is a pathology. Let's remember for now.
So why it is causing the referred pain?
A referred pain is due to the phrenic innervation toward that region.
The air is causing referred pain because of it's irritating the diaphragm and it is causing the pain.
Basically, it is the refer. Can you explain this answer? Why there is a pain referring to the shoulder?
It's irritating the diaphragm.
Yeah, it is irritating this diaphragm, doctor. So this diaphragm have innervation through which
C3,
Phrenic.
are
C4, C5.
yeah. So that lead to the shoulder pain, and in the right shoulder examination is normal. Okay, so there is no any abnormality in this pain, any muscle, no muscle abnormality, no any tender abnormality, no dislocation, no any history of trauma. So right shoulder examination normal. So we have excluded all the differential of the right shoulder directly goes to the referred. This is a referred pain. Have you got the point? Yeah. So
Yes.
I was talking about, just remember for now. We will discuss acute cholecystitis in detail in pathology section. But for now, referred pain to shoulder, number one. For now, acute pancreatitis, referred pain toward back.
Back.
Have you got the point?
Yeah.
Perfect. So these are two important we will discuss in the pathology of the gastroenteritis, and nephrolithiasis we will discuss in the nephrology section, and perforated viscous is a free air under the diaphragm. Okay. And you know the small bowel obstruction. No vomiting, no any distension, no anything. Have you got the point?
So, so what does it mean by viscous? Perforated viscous?
Viscera,
Viscous. Sorry?
Is
it's
does it viscera?
Hollow organ, like a hollow organs.
Organ. Oh, hollow organs. Okay.
Yeah.
Thank you.
You're welcome. So I think it is based simple on the basis of exclusion. If you know a little anatomy of this, then you will exclude all the option, and then you have to just do it. Okay. So any new volunteers? I think we are having 25 students in the batch, and what is Anam Nasar, Ayan Majid, Dr. Chitra, Dr. Divakar, Dr. Amos Boating, Dr. Habibu Tamba, Dr. Huzi. So anyone from new volunteers that you can read this time.
Okay, sir, I can.
What's your good name?
Anamnas.
Okay, Anamnath, go ahead. So the point I heard your name first time. The point to read the question is to from the question, like from the down below. What the question is asking about? Is it a question of anatomy, pathology, pharmacology, or anything else? Whenever you know the question, then go with STEM. Then you will know it is talking about the anatomy and artery. So don't make a more time on this tab. Just go to an artery, and it is talking about artery. Then go to it. Okay, have you got the point?
Yes, sir. So you are
Okay.
telling me to read only the main stem.
No, no. I am telling first of all, read the question. For
Okay.
example, in this, they are asking impeachment of which of the following structure is likely responsible in this patient current condition. So you know this question is of anatomy. Okay.
Yes, sir.
So then go to the stem. If there any sign of any anatomical structure and any hint according to a structure they are asking about, then it will help you. Then don't go to the differential, what is this disease, what is the pathophysiology, what is pathology. Leave it that. If the question is anatomy, just focus on anatomy. I think you have got the point.
Yes, sir.
Okay, go ahead with your read the question and
Impingement of which of the following structure is most likely responsible for this patient's current condition?
okay.
14-year-old girl evaluated in the burn unit due to nausea and recurrent bilious vomiting occurring for the past 4 hours. 12 days ago, patient was admitted to the burn unit after she was in house fire. Examination on admission showed deep and superficial partial thickness burns covering 40% of her body.
Mhm,
Patient has been receiving IV, analgesics, nutritional support, and wound care, with slow improvement in clinical status until today.
mhm,
Temperature is 38.3, BP is 133 on 77, pulse is 108, and then respirations are 22.
mhm,
Finding consistent with those of previous days. Physical examination shows mild diaphoresis with
mhm,
IV contrast demonstrates significant reduction. Sorry. A mild diaphoresis with mild upper abdominal distension.
mhm,
A multiple wound and blood cultures taken since admission is negative.
mhm,
CT scan of the abdomen with IV contrast demonstrates significant reduction of angle between superior mesenteric artery and the aorta,
mhm,
with compression of intervening portion of GI tract.
mhm.
Treatment of which of the following structure is most likely responsible for this patient?
Which of the following is the most likely?
Is it related with duodenum, like third part of the duodenum?
Perfect, perfect, perfect. It's basically the third
Because
part.
of absence of the fat.
Yeah, I think we have explained this question yesterday as well. So for this is your abdominal aorta, and from here, this is your this is your superior mesenteric artery. It goes like that. Let's rotate this film. So whenever I rotate this film, it's like that. And this is your abdominal aorta, and from here your superior mesenteric artery like this. So what structure over here? Your esophagus. So which part of esophagus? Like your
Duodenum.
so duodenum. Sorry, this is your stomach. This is your first part over
Third
here,
part of
second part
duodenum.
over here, then your third part, then a fourth part. Okay, your first part, second part, third part, and here's a fourth part. So here's your artery. So artery is going like this. This is your third part. Okay, third part. So this artery, superior major artery, compresses the third part of duodenum. So there is this angle is reduced to, it is reduced to like this. So there is a compression of this third part of duodenum. Have you got the point?
Yes, sir.
Hmm? Okay. So what's your answer here?
Descending
Transfer,
segment.
transfer segment of the duodenum.
Perfect. It's basically it's your transfer segment of the duodenum. Basically, if you know the first part, second part, and circle very deeply, so that is your transverse part of the duodenum. Okay, you got the point. This was transverse segment of the duodenum. Ascending segment is like this is ascending segment. Okay, this is your transverse segment. This is your fourth part of segment. And if you want to take why not, this is transfer, this is not transverse. If you do go deep into it, it is like that, it is like this one and like this one, it is like this. I got your point. In the first part, second part, third part, fourth part. Okay, yeah, so it is basically the transverse part of tubular, and there is your superior mesenteric vein above the third part of the tubular. Okay, so it's not that a confusing question. So no. Now, any volunteers want to discuss so that we can go ahead? Yeah, any volunteer?
This patient's biopsy specimen was most likely taken from which of the following gastrointestinal sites?
Perfect.
A 54-year-old man is evaluated for episodic abdominal discomfort, blotting sensations, and flatulence, along with the occasional diarrhea. He has neither visible blood in the stool nor unexplained weight loss. The patient has tried avoiding dairy products, but his symptoms did not improve. On examination, there is a mild epigastric tenderness on deep palpation. Stool occult blood testing is positive.
Mhm.
Endoscopic evaluation reveals an area of nodular hyperemic mucosa, which is
Mhm.
biopsy. Histopathology evaluation shows hyperplasia affecting branched tubular submucosal glands
Mhm.
containing alkaline secretion.
Okay.
This patient's biopsy specimen was most likely taken from which of the following GI sites?
Okay. So there is a most important thing to my alkaline secretion and submucosal gland. Okay. Stomach, stomach. Alkaline or acidic?
Acidic.
Acidic.
I think exclusion. Okay.
Yes, sir.
Okay. So what's the point or the jejunum and ileum and colon? So what's present over the jejunum? Basically, the most important thing in jejunum that is present, that is the most important thing that it contains is number one, it secretes a goblet cells that secrete mucus. Number second, it contains enterocytes, the cell of intestine that secrete water plus electrolyte. Okay?
Okay.
and there is a less chances to secrete a bicarbonate or alkaline secretion. And the most important thing in jejunum is there's no any submucosal gland present over here. Okay. What's the terminal ileum and the transverse colon? In the ileum, there is no any submucosal gland are not present in any of these. Number one, submucosal gland not present in this. In terminal ileum, you will find any villous epithelial cell, and I've got the point. No, any there will be a bacterial present in over here. Okay. Okay. Yeah. So the first part of duodenum that it contain the submucosal. So what the glands, submucosal glands, the name of that gland?
Runner glands.
Yeah, Brunner gland. Perfect. So the Brunner gland are present in the duodenum. So basically, there are two type of secretions present in the duodenum. Okay, number one, that the Brunner gland secretes. Brunner gland secretes. Anyone?
Bicarbonate.
Bicarbonate.
Perfect. True neutralizes the acidic environment of the stomach. Okay, so alkaline secretion like that. Okay, and second, there is the secretion that are high in the first part of duodenum, and that is
Pancreatic.
pancreatic secretion, that is ampulla of water. Okay, so pancreatic secretion secrete a bicarbonate to neutralize the secretion of the duodenum. Okay, first part of the duodenum. Okay, so basically, the most important thing is this is histopathology. Okay, and note that it is simple. Show hyperplasia affecting the branch, submucosal gland, and contain alkaline secretion. Okay, the patient biopsy. I told you the CT scan X-ray, the histopathological, and for the pathology to look at the stem. Okay, to know the pathognomonic sign of each disease. Okay, so in here in this question, antrum and stomach is acidic, jejunum ileum does not contain any submucosal gland. So on the basis of exclusion, you can directly go with the first part of duodenum. So if you know what's the first part of duodenum, so you can directly go and take the option D. So if you don't know the answer, then go on the exclusion process. Okay. Okay.
Yes, sir.
Oh, perfect. That's the perfect one. So it's the first part of duodenum. It's a new question or old one? The patient biopsy specimen was most likely taken from which of the following gastrointestinal? Oh yeah, it is the old one. This is the first part of duodenum. Okay.
Before starting.
Thank you very much. So any volunteer wanna join the section of
Yeah, the reason.
what's your good name,
Hello.
doc? What's your good name?
The reason Mohammed Mohammed Saidu Mazari.
Okay, good. Go ahead, doctor.
Yeah. The reason that we consider the first part of the duodenum is based on the how the case is being described. Uh, we have what we call the episodic abdominal discomfort resulting, and then that of the fluid trend. And we also see that there is depositing fluid blood in the stool, and then there is an endoscopy shows that there is a nodular hyperemeric mucosa, and when it is being biopsied, there is also an hyperplasia of the branch tubulum submucosa gland with
Mhm.
alkaline secretion. So
Mm-hmm.
this for
So,
adrenal gland anesthesia,
mm-hmm.
which is found in the first part of the duodenum.
Yeah, yeah, yeah. You are talking right. I got your point.
Yeah.
Oh, thank you. So, can you please read the answer? Go with the second question, 15 number. Yeah, doctor, go
Let me
ahead.
read, sir.
Yeah, go.
During surgery, which of the following landmarks is most helpful in identifying the disease organ?
Perfect. Yeah.
A 17-year-old girl is brought to the hospital due to abdominal pain, nausea, and vomiting. She
Mm-hmm.
began having periumbilical pain and nausea several hours ago and initially attributed her symptoms to some bad food she ate at a potluck lunch earlier in the day.
Mm-hmm.
However, her pain progressively worsened and became localized to the right lower quadrant. Temperature is 101 Fahrenheit. Blood pressure is 124/78.
Mm-hmm.
Pulse 92 and respiration 14.
Mm-hmm.
On examination, the patient has right lower quadrant tenderness with guardian.
Yeah.
Laboratory evaluation shows leukocytosis.
Perfect.
Surgical intervention is planned during which surgery, which of the following landmarks is most
Yeah.
helpful in identifying the
So
disease
basically,
organ.
yeah, perfect. Thank you. So right lower quadrant tenderness with a guarding, and there is a leukocytosis present over here. For example, this is your abdomen, and this is your umbilicus. So pain is over here. Right lower quadrant pain, high leukocytosis. The topmost differential diagnosis is
Acute appendicitis.
acute appendicitis. Acute appendicitis. I got the point. Now, which of the following is your the surgical landmark is more helpful in identifying the disease organ? So, which of the following is the most likely in this patient? So, what is it? Greater momentum. Where the greater momentum present? Like here is your greater. So, greater momentum is present over here, right?
Yes.
So, is there anything related with appendicitis?
No.
No. Ulcer of the colon, ulcer form like what? Let's discuss what is the lesser momentum.
Large intestine, right?
Yeah, yeah. What is the lesser momentum? So lesser momentum are
Yes,
like this is your liver, so this is your lesser momentum for here. So this is your hepatoduodenal ligament, two type of lesser momentum, and hepatogastric ligament. Okay, so this has no any concern with appendicitis. Okay,
Yes.
and
Okay.
what is the psoas muscle related to it? It's a psoas sign that present in the acute appendicitis. Psoas muscle, if whenever you extend the muscle of the psoas, it relieves the pain. So it is associated, but it is not the landmark of it is not the surgical landmark in this case. And how the hostra, so hostra are like, for example, this is your colon, it's like this, and here is your ileocecal wall is present over here, and this is your ileum, and there's small appendix over here, and hostra are all around this one. Okay, so this hostra is basically whenever you go a surgery of the appendicitis. So there is another landmark, the tinea coli. Tinea coli like goes longitudinally. It longitudinally goes like this, also from this side, and also from this side. Okay, so this is called a tinea coli. Okay, during surgery, during the surgery, whenever you find not finding any clue that where is appendicitis present, So basically, at the there is a three longitudinal bands like structure. This is a clinical that goes to the till the sigmoid. Okay, so it is a similar function as the muscularis externa in the digestion. So whenever during the surgery, if the appendix is not identified by palpation during appendectomy, then it is located through through this tinea coli. Like whenever you put a hand over here and go down, 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 down toward the base of the cecum where there is a no tinea coli, then come over here, so there will be an inflamed appendix present over here. Have you got the point? When there
Yes.
is no landmark on the no palpation of this inflamed appendix, then a surgeon go from this area down, down, down. Whenever there is no tinea coli is present in this area, so this is the landmark of the appendix. So this is surgical landmark is helpful in finding the appendix and help in appendectomy. Have you got the point?
Yes.
Yes, sir.
But yeah, so tinea coli is the three longitudinal bands that go from cecum up to the sigmoid, and it is helpful in appendectomy. That's the point. Okay, so just remember a small point that help you that and it's also not that high yield question, but it's helpful in the step 2 of your exam. As you know, if you clear your step 1 exam in step 2 course, there is a 70% step 1 present here. Okay, whenever you look into the step 2 course, okay, if you are going to step 2, okay, step 2 is having a 70% step 1, and the rest you have to go through your medicine and surgery and peds and like this one. So it is 30% medicine and surgery, and 70% is step 1. So if you study well in the step 1, so you will it will be easy for you to clear the step 2 exam. Okay, so any new volunteer wanna go with the question?
Hi, my name is Sonny.
Okay,
Mm,
Sonny, go ahead.
This patient condition is most likely due to inadequate relaxation of which of the following muscles during defecation.
Hmm?
A 74-year-old man comes to the office due to chronic constipation.
No,
Bowel movements,
this is asking about the muscle or the nerve. Which is the following
which of
nerve?
the following
Muscles, right?
Okay,
muscles?
okay, muscle. Okay, okay, go ahead.
A 74-year-old man comes to the office due to chronic constipation. Bowel
Mhm.
movements occur once every 3 days and are hard and pellet like. The patient frequently strains when he tries to defecate and never feels completely evacuate. The constipation is occasionally so severe that he uses his fingers to remove stool from the anorectal vault.
Hmm?
Medical history is significant for Parkinson disease, for which he takes carbidopa levodopa. Vital signs are unremarkable. A resting tremor is present on physical examination. The abdomen is distended but non-tender to palpation. This patient's condition is most likely due to inadequate relaxation of which of the following muscle during defecation.
Yeah. So let exclude on the basis of the exclusion. Okay, bulbous spongiosis. It is present in
Pe- penis.
help in erection, right?
Yeah.
So is it helpful in defecation?
No, not
No.
No.
related to constipation.
Okay. What's the obturator? Is there any relation to this? Because obturator muscle is present in the hip joint and it helps to rotate lateral hip
Sir, I
rotate.
get the recording of the session.
No,
Yeah, it's
no.
also recording. Yeah, perfect. So it is a lateral rotator of the hip joint, and a piriformis is also the lateral. Both are the lateral rotation of the hip joint. What the rectus abdominis muscle or the pubis rectalis. The rectal abdominal muscle are along the anterior abdominal wall that help in the expulsion of the feces. Okay, but it is not that in the condition is equal in the relaxation which of the following muscle identification. So pubis rectalis, for example, this is your pubis symphysis, and here your backbone. Okay, so here's your sigmoid colon and then rectum. Okay, here. So pubis rectalis muscle start from the pubis and it goes around the rectum and then insert into the pubis. Okay, so whenever this contract, this will stop the defecation of this muscle. Have you got the point? Puborectalis. It's acting like a sphincter. Have you got the point?
So can you
Yes.
Yes.
repeat that one more, please?
Sorry?
Can you repeat it, please?
Okay. This is your pubis symphysis.
Yeah.
This is your backbone. Okay.
Yeah.
And here the sigmoid and then your rectum. Okay. The anal canal.
Mm.
This puborectalis muscle start over here and insert back into pubis symphysis and goes around the rectum and act as a sphincter.
Oh,
Okay. When
okay.
it relaxes, feces go down. When it contracts, the feces present in this.
Mm.
Okay. So
Okay.
it is a skeletal muscle. So it is external sphincters. It help in to relieve the defecation or to remove and help. Have you got the point?
Yes, sir. Yes. Thank you
On
so
the
So,
much.
basis of
sir, so sir, in this patient, we would give the muscle relaxant.
yeah, to have giving the muscle relaxation help in the patient to like you can go with exercise like that. And the patient having a the patient also having a Parkinson disease. Okay, on the and Parkinson disease in having the patient of the carbilevidopa. But whenever there is a neurological problem going on, so there will be a neurological defect as well. So whatever the nerve supplying this is also a problem, like present in multiple sclerosis as well, like a Parkinson disease, like multiple sclerosis. The nerve innervation is relaxed, so this muscle is not that working properly. Have you got the point? So
Yes, sir.
that will lead to the functional disorder. Okay, and that is common in the neurological disorder as well. But on the basis of the as you know, I told you the patient is conditioned most likely relaxation which of the following muscle. Okay, so it is straightforward MCQs of the anatomy, which muscle they are asking about. If you go deep into the Parkinson system, sclerosis, and what happened, you will be get confused. Okay, directly go which muscle is present in the rectum. Okay, of bulbous spongiosis penis, obturator lateral hip rotator, piriformis lateral hip rotator, rectus abdominis not helping in the present anterior abdominal or puborectalis. That is the basis of this. So you know the just basics of the anatomy. So anatomy question they're difficult, but you have to clear the concept of the clear remembering. I told you remembering is important. Have you got the point?
Yes, sir.
Perfect. Yeah. Any volunteers?
Yes, I am
Yeah, doctor.
Mohammed Saidu Mansari.
Yeah, doctor. Go ahead.
Which of the following injuries is most likely to be responsible for the patient's internal bleeding?
Mhm.
A39, which of the following injuries is more likely to be responsible for this patient's internal bleeding?
Mm,
A
mm,
39-year-old woman
mm,
is emergency department
mm,
after an end-to-end motor vehicle collision.
mm.
She was a restrained passenger and did not hit her head or lost consciousness. She has had abdominal pain and
Mhm,
nausea. The collision. Blood pressure is 116 over 56.5 millimeter per mercury, and the pulse is 96 and beats per minute and
mhm,
regular. On examination, she has enchymiosis
mhm.
over the area of the seat
Okay.
belt
Mhm,
and abdominal tenderness.
mhm.
CT scan of the abdomen reveals erectroperitoneal hematoma.
Perfect.
So this
Mhm.
is it. Yeah. So which
Yeah.
of the following injuries is most likely to be responsible for this patient's internal bleeding?
Thank you, doctor. So CT scan abdominal show reveals the retroperitoneal hematoma, the which of the following injury is the post-plastic patient internal bleeding. So point to be noted here there. So what are the structures that are present in retroperitoneum? So retroperitoneum mean, for example, this is your organ for okay. So if it is present in only anteriorly by a peritoneum, no posterior peritoneum. This is called your retroperitoneum organ. When there is a peritoneum that covering from both the side, this is called intraperitoneal organ. So it's important in anatomy to differentiate which of the following structures are present in retroperitoneal structures. Okay, to go with the detail, let's discuss a little and it's also come under the remembering process. You have to remember the point. So which of the following is the retroperitoneal organ? Number one, esophagus. Okay, remember that it is covered only anteriorly.
But we can
Number
have mnemonic for this, right? Like sad pucker.
Yeah, said Bakar also. I don't have that ability to uh yeah. Doctor asking a question that hosta are small pouches and circulation formed by the contraction of tinea coli help in the colon and giving it a segmental appearance. Yes, doctor. Yeah, yeah, yeah. Perfect. So I think it's giving answer to one, but yeah. So basically, it's a sad pucker mnemonic, but for the mnemonic, I'm not that good. For the anatomy, I go with a Natter Atlas. I use that only images I remember. I don't remember the sad pucker. If wanna go with a sad pucker, let go with a sad pucker. But I don't know what the sad pucker mean. PU
CKER.
PU
CKER.
say key. So what's S?
Suprarenal gland.
Perfect. Suprarenal gland that is present in what's E?
Aorta.
Okay. Aorta. What's D?
Duodenum.
Which part of duodenum?
Second and fourth.
Like two and four or two and three.
2, 3, 4.
Yeah. Except the first part, all the duodenum is retroperitoneal. Okay.
Yes.
And P?
Pancreas.
Perfect. U
Ureter.
and the ureter. Okay. C?
Colon.
Which part of colon?
Ascending part.
Ascending and descending both.
Ascending and descending both are the
Uh,
retroperitoneal.
And in
Okay.
case for kidneys,
Okay, kidney, E.
esophagus, and rectum.
Perfect. Esophagus and rectum. And which part of rectum? Proximal or distal?
The proximal part of the rectum.
It is the mid distal part.
Okay, sorry.
Okay, go with the anatomy to look the atlas. If you look into the atlas, you will remember, you will imagine your whole anatomy in one page. Okay, so it also a simplest form set Pucker. I don't remember that, but you have go with it. So can anybody can give the answer on the basis of the set Pucker, a contusion of the body. So which part of the pancreas?
Why
SAD.
can't they explain once anatomically, like fastly? Maybe it is easy to remember.
Okay, let's go ahead. Basically, it's you have to go with the book. So I haven't have a page of Netter Atlas. I remember once here, but go with it. So whenever you go down, for example, this is your whole program over here. Okay, posteriorly they are having a two kidneys. Okay, over here, and there is your vein. So vein is intraperitoneal or retroperitoneal?
Intraperitoneal.
Vein is your inferior vena cava is intraperitoneum or retroperitoneum. So what happened inside Pakar?
It's retroperitoneal,
Retroperitoneal.
retroperitoneal.
So is there any chance of inferior vena cava?
It's like aorta and IVC both.
So I think it's not present in this mnemonic, right? Inferior
No,
vena
no,
cava.
it's not available. It's
Yeah, yeah.
aorta
So
and IVC.
both are present. So let's go. Let's remove the said Pakar and then go with the anatomy. It is left side, right side, sorry, and it's your left side. Okay, have you got the point?
The body.
Yeah. Now, I will only draw the structures that are retroperitoneum. Okay?
Okay. The pancreas. Duodenum. Um, kidney.
Suprarenal. Okay. The okay. It's your second part of duodenum and third part of duodenum. Have you got the point? Okay. Let have with the dark marker. Your straws are present over here. Okay. Let mark is on the dark side. Okay. And they descending. Go down. Okay. Are you getting the ideas? This is all the retroperitoneum organ present in it. Okay. This is your what this organ? What's this?
Ureter.
Perfect. So why not are you responding that is ureter? Okay. And this is the distal part of the rectum, not the proximal part. Okay. Now,
Mm-hmm.
one more thing important over here is that you will having a pancreas. Okay. Mm, and pancreas is not full. Tail, not a tail, body, and the head. Okay. Let's discuss it. Let's discuss from the whole body. Is your esophagus present over here? Now, from the upward, there is inferior vena cava Okay,
Yeah.
aorta, esophagus. Okay, esophagus. And what these structures? Adrenal glands. Okay, kidneys, ureter, colon. That is descending and ascending colon. Okay, distal rectum. Anything left? The duodenum.
Pancreas.
Yeah, duodenum. Second plus third part. And pancreas, body
Head.
plus head. Head and body, not a tail. Okay, have you got the point?
Yes, sir.
Have you got any idea from this picture?
A very good idea, sir.
Thank you very much, doctor. So that you remember from this. So whenever you
We can
go and sorry,
we can remember the picture better.
thank you very much. So as
Hopefully, better
yeah,
now.
thank you. So I also prefer to go with the picture. Whenever you see an Atlas Network book, you will see a brilliant picture of this picture, the and retro peritoneal organ. So I'm many almost 90 to 80 to 90% students for the step one use the abbreviations like one of students says at Pakar. So in Packer, you have to remember what the S, what the A, what the D, what the P, what the U, and what the C. So it's also I thought it's inferior. Okay, when a K was not there present. If you saw the duodenum, so it not mentioned which part of duodenum. It's a pancreas, which part of pancreas. Is the rectum, which part of the rectum. So whenever you go to that picture, you will clearly crystal know which is your correct option. Have you got the point? So which of the following is a retroperitoneal contusion to the body of the pancreas? It is retroperitoneal or intraperitoneal?
Retro.
Retro. Okay. And the spleen, intra, right, intra, stomach, intra. Have you got the point?
Yes, sir.
Proximal part of the intra.
Intra. Hmm.
So can we correct it? Perfect.
Yeah.
That's the point. To remember to gain. Okay. Oh, that's another point.
Structure.
Another CT
Yeah,
scan.
CT
Go
scan. Yeah,
ahead.
good.
Now you have to tell me. Wait a minute. Let go just to the structure. What's A? Can anyone tell me?
Inferior vena cava.
Aorta.
Wait a wait a minute. Wait a minute. Wait. This is your wait a
Body.
minute.
And
So this is your
aorta.
Aorta.
perfect. What's the C toward the left right side?
IVC.
Esophagus.
IVC.
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 Perfect. So you know this is IVC and this is your aorta. So what this?
Liver.
Liver.
Yeah.
Yeah.
What this?
Right
Kidney.
knee. Sorry, left knee.
Kidneys.
That's
Yeah,
the
right.
kidney.
Kidneys.
No, left.
That the kidney. Yeah. What this?
Pancreas.
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 That your pancreas. So what's A?
Portal.
Per,
Duodenum.
perfect. That's a duodenum. I think you have a
Okay.
little concept of the CT scan. Okay. Now move toward the question. What's the question asking? Okay.
Doctors,
Okay.
sorry,
So
but I mean here, how we will know this is a duodenum or a portal vein? Because
yeah,
at that previous one, it was the portal. So
yeah. There's a point, but just remember.
maybe according to the cut, I don't know.
According to
Yeah,
the
yeah, yeah.
cut.
Yeah,
Yeah.
it's according to the cut. Whenever you
Yeah.
see, whenever you see the pancreas, so it's the first part of duodenum. When it's the cuts go down or up, whenever it's the level of your, if there the whole kidney present over here, sorry, whole liver, so its cut is uppercut.
Yeah, to be
If you are going downward, you will see the kidney, so it's the down
Mm.
cut.
Okay, good.
Okay,
Yeah. Thank you.
very welcome. So let's to toward the stem. A CT scan of abdomen is shown in the image below. Involvement of which of the following structure is most likely causing this patient? A 48-year-old man is evaluated for the abdominal pain and diarrhea. The patient characterizes his stool as a voluminous and foul smelling. So foul smelling, okay?
Okay.
Foul smelling mean fat in it.
Mm.
He has no significant past medical history. He drinks 6 cans of beer. Examination. He has normal bowel sound and mild epigastric pain. 72 or collection excessive secretion of fat. Okay. Without this test, I told on the basis of the history that it is fat. Okay. A CT
Mm.
scan of abdomen is shown in this image. Below which of the following structures is most likely involved in the patient? So fat.
Pancreas.
Pancreas.
Perfect. Yeah, almost. So which of the following is the pancreas?
B.
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 I think you have clear crystal the concept of the CT scan anatomy. Perfect.
Yes, sir, thank you.
You're welcome. Now, another World War III. Come on.
If this mass continue to enlarge, which of the following structure is most likely to be compromised in this patient?
All right,
A
perfect.
60 A
Mhm,
65-year-old man is evaluated in the clinic due
mhm.
to several months of abdominal pain and vomiting. The pain starts 2 to 3 hours after meals, is characterized as crampy and is often associated with bilious vomiting. Lately, the patient has been tolerating only liquid and has consequently lost 12 pounds in the past 4 months. On physical examination, he has mild epigastric tenderness on deep palpation. Contrast enhanced CT scan of the abdomen show an irregular mass in the third portion of the duodenum that is infiltrating behind the gut wall. If this mass continue to enlarge, which of the following structure is most likely to be compromised in this patient?
Perfect. Simple. Okay. Have you got the answer?
Superior mesenteric artery.
Yes,
I will
sir.
think you clear the concept.
Yes, sir.
Perfect. Go ahead.
This patient's condition is most likely caused by which of the following? A
Mhm,
62-year-old man comes to the physician due to intermittent groin pain. The
mhm,
pain is most severe when the patient lifts heavy loads and after a long day at his job as a construction worker. Physical examination show a right-sided groin bulge directly above the inguinal ligament. The bulge increases in size when he bears down. An ultrasound reveals that the mass originates medial to the inferior epigastric vessel. This patient's condition is most likely caused by which of the following? Failure of the internal inguinal ring to close, patent processus vaginalis,
mhm.
separation of the abdominal muscle Weakness of the transversalis fascia, widening of the femoral ring.
Let's discuss the extractive mode. And okay. Hernias. Let's discuss the hernias. Okay, they're basically the two type of hernia: indirect hernia and the direct hernia. Okay, this is your, for example, this is your inguinal ligament. Okay,
Okay.
I will discuss one question, this, then you will automatically give rest answer by yourself. Now go to the concept. Okay, this is your deep inguinal ring. This is your superficial inguinal ring. Okay, and this is your the okay. The spermated cord go over here and goes down and like this. This is your deep inguinal ring. Okay, deep, and this is your superficial. Okay, now the most important thing in the hernias are inferior vessel, inferior epigastric vessel, either vein or artery. Now, the most important thing to remember is the inferior gastric vein. Let okay, it very clear. Inferior gastric vein, and where I draw, this is right side, this is left side. So, where should I draw a vessel of artery? Left side or right side?
The medial side will become left, right?
Left side is arterial side.
Left side.
Yeah.
Left
Okay.
side. Okay.
So don't confuse, but this is a general concept. It fits in 90 as 80 to 90% of cases. Okay. Now it is your spermated cord going on like this and like this, superficial deep inguinal ring, superficial inguinal ring, and inferior epigastric vessels. I've got the point now. This is your vein, femoral vein, femoral artery, and the nerve. So your nerve, okay? Shit. Okay. So your nerve going out here. I got the point. Now, in this scenario, now let's discuss it. If the bulging of the intestine through the superficial inguinal ring directly from here and protrusion intestine to this directly. So this is called the direct inguinal hernia. Okay, the protrusion of the intestine through the superficial inguinal ring directly through superficial inguinal ring. This is called direct hernia, and it is medial to the epigastric direct and medial to epigastric inferior epigastric vessels. Okay, that is indirect. What happened to the indirect? Indirect are from the, for example, there is having a loop that is go through this deep inguinal ring, then go through the superficial inguinal ring over here. So this is indirect. It is not directly going from the direct. It is indirect going from deep inguinal ring, then superficial inguinal ring, and it is indirect and it is lateral to epigastric vessels. It's lateral and it's medial. Have you got the point till now? Now, okay.
So what did you say? Lateral medial? Which one is?
This is the direct inguinal hernia is medial to the epigastric vessels,
Okay.
and the indirect hernia is lateral to the epigastric vessel. The main landmark is the epigastric vessel. If it is medial to it, it is indirect hernia. If it's lateral to it, is indirect hernia. And indirect hernia goes to the deep inguinal ring, then superficial inguinal ring. And direct hernia directly goes to the superficial inguinal ring. Have you got the point?
Yes, sir.
Perfect. Now, what is the pathology in direct hernia and indirect hernia? Let's discuss it. So the main pathological in the direct hernia is the transverse fascia, transversalis fascia that present that come from the rectus abdominis and over here that weakens, and that weakens in the old age. Okay, so there is a problem in transversalis fascia, and that are present mainly in old age. You got the point. And what the pathophysiology of indirect hernia? That's over here. Basically, there is a patent processus vaginalis. Do you know processus vaginalis? The pathology is the patent processus vaginalis. Have you got the point?
Yes.
Perfect. Now, I think you have clear the concept of the hernia. What is direct, what is indirect. Okay,
Mm-hmm.
go ahead. Can I go ahead?
Yes.
Okay, now come to the question. What the question is asking about. Okay,
Yes,
ultrasound.
patients.
The ultrasound reveal having
Medial
a.
to the inferior epigastric vessel.
What do you think? What type of
Direct.
hernia? What type
Direct
of
hernia. Direct.
direct? I think you have clear your concept. Now the cause of this direct is due to.
Weakness
Weak.
of the transversalis fascia.
Yeah, so it is the weakness of the
Yeah,
transversalis
transverse
fascia.
fascia also.
Have you got the point?
Yes.
That's the point. So you have directly go and click on this option. Okay,
Okay,
Okay.
sir.
perfect.
Which
Now,
of the following landmarks will best aid the surgeon in distinguishing an indirect from a direct inguinal hernia?
yeah, give
A
me
full,
answer. Give me answer. I have told
okay.
you. Which of
Inferior
all?
gastric vessels.
This. Yeah.
Yeah,
B.
Inferior
perfect.
epigastric
Which of the
vessel.
four led what surgeon would explain for indirect and direct? I think all of have cleared the concept.
Yes.
Yes, sir.
If
Perfect.
you that vessels.
Epigastric vessels. Perfect. Now, come on.
The overlying skin is erythematous. Which
Mhm.
of the following structures is most likely immediately lateral to the bulge? A 65-year-old woman comes to emergency department due to nausea, vomiting, and abdominal pain that began about 6 hours ago. She
Mhm.
has also had wage pelvic pain over the last few months, but says her pain has never been this severe.
Mhm.
Temperature is 38.4. Blood pressure 141 by 90.
Mhm.
Pulse is 92. Respirations 18. Physical exam shows a moderately distended abdomen. There is a tender bulge below the inguinal ligament,
Mhm.
lateral to the pubic tubercle. The overlying skin is erythematous. Which of the following structures is most likely immediately lateral to the bulge?
Oh, yeah, it's a one more question over here. Let's discuss it. So I discussed the direct hernia, number two, indirect hernia. Now, a third type, a very rare type, and that is a woman, is a femoral hernia. Okay, basically, this is your inguinal
Mm-hmm.
ligament. Inguinal
Mm-hmm.
ligament. This is your pubic tubercle over here. Okay, and this is iliac spine. Okay, and now this is your deep inguinal ring, and this is your superficial inguinal ring over here. Okay, and here's your femoral vein, femoral artery, and nerve. Okay, epigastric vessels over here. Okay, now if the intestine are through this, what is this called?
Superficial. Direct.
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 And how when it is go through this pathway?
Indirect hernia.
If it is
Indirect.
direct, if it is go directly through this pathway, without this and without this hernia is called femoral hernia. Okay, it's not disturbing the deep inguinal ring, not disturbing the uh superficial inguinal ring. It is going with the below the inguinal ligament. It is below the inguinal ligament. Okay, and it
So
is
you're saying, so if it
sorry.
goes below the inguinal ligament, it's femoral hernia?
Yeah, it's a femoral.
So they won't mention
Mm-hmm.
anything about the superficial ring or deep ring. It's just hernia is
Uh,
just going
yeah,
below the.
yeah, they will be mentioning the epigastric vessel. If they are talking about the indirect or direct, they will mention the epigastric vessels.
Mm-hmm.
Oh,
Okay, so
okay.
there is a tender bulge below the iguanal ligament. Below the iguanal ligament, number one point. It is through the superficial inguinal ring. It is through the deep inguinal ring between toward the superficial inguinal ring. Have you noticed my words? And it is below the inguinal ligament and lateral to the pubic tubercle. This one. Have you got the point?
Mm-hmm.
Yes.
Okay.
Sir.
Okay.
Yes, sir. Yeah.
So, which of the following structures are most immediately lateral to the bulge? So, this is bulge. Lateral to it is
Inferior
Femoral.
epigastric.
what is
Femoral
this?
vein.
What
Femoral
is
vein.
yeah? This femoral
Vein.
vein over here. This is femoral artery, and this is your nerve. Okay.
Yes, sir.
Yes.
So, femoral vein.
Femoral
Have you
vein.
got your direct hernia export, indirect hernia export, and femoral hernia export? Got it? Yeah. It's the last question
I
of the
can go.
today. Yeah. What's your good name?
My name is Shravya, sir.
Shrabi. Oh, good, Shrabi. Go ahead.
Sir. Rubber band ligation of the lesion is most likely to involve which of the following? A
Mhm.
42-year-old man comes to the office with rectal bleeding. He used to have occasional streaks of blood on the tissue after wiping, but for the past several days he has had seen blood dripping into the toilet at the end of defecation. The patient reports chronic constipation and has to strain while having a bowel movement but has no rectal or abdominal pain. He works as a truck driver and his diet consists mainly of hamburgers and french fries. Abdominal examination is unremarkable. There is no mass or tenderness on digital examination, but anoscopy shows bulging purplish blue mucosal lesion above the dentate line. Rubber band ligation of the lesion is most likely to involve which of the following?
Perfect, perfect, perfect. Let's discuss the hemorrhoids. Last topic is hemorrhoids. Do you wanna discuss it now, or can I continue with tomorrow?
Here I have a quick doubt. Is rubber band and the gastric band the same that we discussed yesterday?
No, 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 no.
Okay.
Rubber band is and gastric band are two different things. And the gastric band are for the bariatric surgeries, help in reducing the weight. Okay, and from the band like ligation, that rubber band ligation that help in hemorrhoids. Okay, so now it's your choice. Can we discuss the
Sir, please
hemorrhoid?
continue. Yeah.
Do you want to discuss hemorrhoid today, or I will discuss it tomorrow? It depends upon yours. If you are not full, then I will discuss it. If you are full,
Sir,
because
please discuss today.
okay,
Let's
okay.
have today, doctor.
Okay,
Yeah.
let's finish it today. Okay, perfect. I think it's anatomy. We have discussed the celiac arteries, the arteries, the veins, hernias, and okay. So now discuss the hemorrhoids in the short. Hemorrhoids, anorectal venous drainage malformation. Okay, now what is important in the and to know what is superficial, the deep guanal, the hemorrhoids, internal hemorrhoids and external hemorrhoids. Okay. For example, let's discuss the point over here. For example, this is your rectum. This is your dentate line over here, and this is your rest of it. This is your dentate line. Okay. Now, above the dentate line, this is called internal hemorrhoids. Okay. And below the dental line is external hemorrhoids. And what other name for the internal hemorrhoid is? Do you know another name? Nah. External hemorrhoid is also called a superficial hemorrhoids. Okay. Now, let's discuss the important thing over here, clinical features to how will we differentiate on the basis of the history. If you ask the patient, whenever you defecate, the pain is present or not, and the patient says the pain present, so it means it come under external hemorrhoid because there is a somatic innervation over here, pain over here, so that will refer pain toward the somatic. Okay. Whenever there is a painless hemorrhoids that will present in the
Internal.
internal hemorrhoid. So these are the clinical features. Whenever you call the patient, or on the basis of history, you ask the patient, you defecate, whenever you defecate, you feel a pain or not. If a no, you exclude the
Internal.
if there is a pain,
External.
external. No pain, painless, internal. Okay. Now
Okay.
let's discuss a point, the arterial supply of this system, the venous supply. It is basically hemorrhoids are the bulging of the vein. Okay.
Yeah.
Now discuss. Basically, this is supplied by a system, it's the caval system, and it is basically the a rectal veins and that drain into your portal system. Why a superior rectal vein? A rectal vein then drain to a superior rectal vein, and that superior rectal vein drain into inferior mesenteric vein, and inferior mesenteric vein combined with a splenic vein, and splenic vein whenever combined with a inferior mesenteric vein, and that the name changes the portal vein. Okay, now what's happening to the external hemorrhoids over here? Arterial supply it over here, a venous supply over here and over here is through the internal iliac vein. Okay, basically internal iliac vein come over here, internal iliac vein, right? So that give a branch that is called a middle and inferior rectal vein or superior rectal vein. Okay, so just know it is through the caval system. Okay, so that give a superior rectal vein over here, an inferior rectal vein over here. Okay, you got the point?
So what is the vein, sir? The big one you drew on top?
The is an internal iliac vein. Internal iliac vein that give a branch to the superior rectal vein and sorry, middle, and there is the inferior rectal vein. So it is basically involving the interior internal iliac artery, internal iliac vein, and superior rectal vein to the painless internal hemorrhoids. So you know the venous supply of this. So below the dentate line, so there will be having now. I think you have got the concept of hemorrhoids till now. Okay.
Sir, just a quick question. So the external hemorrhoids, they are supplied by the inferior rectal vein, which is branch of internal iliac vein.
Hmm?
Okay, wait. I just wanted to clear that, sir. So thank
Oh,
you.
welcome. Now, I think you have cleared the concept, you clear the picture of the hemorrhoids, internal and external. Let's come to the topic. There's a no mass, there is a no mass and or tenderness in digital inflammation, but endoscopic fibrillation above the dentate line.
That means it's an internal hemorrhoid.
That
Right?
is internal hemorrhoid. Perfect. So it means this is the internal hemorrhoids. So rubber band ligation of which of the vein you have? What is your answer over here?
Inferior mesenteric vein, tributary.
Inferior mesenteric vein. Perfect. If there is, if it is below the dentate line, what will be your vein? Internal
Internal iliac.
iliac vein. Perfect. Thing you have got the answer. And one thing I want to tell the moon, while having a bowel movement and has a no rectal and abdominal pain. So it's also giving hint toward the internal hemorrhoids. Have you got the point?
Yeah.
Yeah.
Perfect. That's the main point you have. I think you have gained too much concept today. The hernias are more important and that are highly tested in step 1 question. Almost 4 to 5 questions of will be present on hernia, and the hemorrhoids 1 to 2 questions from the hemorrhoids will be present. Okay, so this was all about today topic. And how was today topic? Kindly give me your feedback in the group so that I motivate, so I know the students are gaining more concepts. Okay.
It's a very good
It was a
lecture, sir,
great
because
session,
the
sir.
Yeah,
anatomy and
actually.
CT scan images are always a nightmare for me. So you
Mm.
made it very easy for us.
Same. And those hernia, every time I used to get confused with direct and indirect and those
Mm.
retroperated detailed structures you just showed with the diagram. It made so clear. Thank you so much, sir.
Perfect, perfect. So kindly give me your feedback in the group as well, so that many students that are not in the discussion, so they also join the group, so they have help in the to clear the exam in next 2 to 3 months. Okay. And any question do you want to know, or that ends the today topics over here. Okay, doctor.
No, sir,
So
Thank
it's
you so
okay.
much, sir.
Thank you
thank
Thank
you
you
so
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 much.
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 Thank you
Session.
so much.
Thank you so much.
Thank you so much, doctor. Bye bye. Thank you very
Bye
much.
bye.
Bye
Take
bye.
care.
You thank
Bye.
Take care. Bye bye.
yeah.